Hello. Today we are going to talk about jaundice first, and then we are going to discuss some cases. And with these cases, we are going to review all the diseases we have covered until now. This is the cycle of hemoglobin to bilirubin. In spleen, senescent red cells, red cells have a limited lifespan, like 120 days. And when they lose their membranes flexibility, they are trapped in the fine capillaries of spleen, and then they are destructed by macrophages. And the content is released. Hemoglobin is converted into its components, and hem is converted to biliverdin. Biliverdin is converted to unconjugated bilirubin, and unconjugated bilirubin is released into circulation. In circulation, unconjugated bilirubin should be bound to albumin to be transported to liver, because it is lipid soluble but not water soluble. So in the circulation, it should be bound to albumin to be carried to liver. In liver, with a special type of receptors, it is taken into hepatocytes, and in hepatocytes, the enzyme which is responsible for the conversion of bilirubin from unconjugated to conjugated bilirubin is activated, and conjugated bilirubin is produced. Then conjugated bilirubin is excreted alongside with bile salts into the bile ducts, and finally it finds its way into intestine. And in intestine, in small intestine, it is again converted, deconverted to unconjugated bilirubin, and then urobilinogen and stercobilinogen. Urobilinogen is converted to urobilin and stercobilinogen to stercobilin, and these compounds with bile salts, some of these compounds are reabsorbed into portal vein, and then goes into enterohepatic circulation. Some urobilin and stercobilin in this process are entering into circulation and excreted by urine. And urine color is produced by this urobilin. This is the cycle of bilirubin. There may be several derangements in this process. We are going to see in the forthcoming slides. For example, if there is hemolysis means that there is an excessive destruction of red blood cells. It may happen in some types of red blood cell abnormalities, like hereditary spherocytosis, in that the erythrocyte membrane is rigid than usual. So it can be destructed in spleen before they complete their life cycle. So there is excessive destruction. This is called as hemolysis. In some patients, there may be antibodies in the circulation against red blood cells. For example, it may happen in some autoimmune type of hemolytic anemia, and they are destructed in the circulation. So the destruction may either be in spleen or in circulation, outside of spleen, in vascular bed. In these diseases, there are some others like sickle cell anemia. This is also characterized by hemolysis. In some infectious conditions, and in a condition which is called as disseminated intravascular coagulation. In all these conditions, they will be told to you in hematology lectures, are resulting with excessive biliverdin and unconjugated bilirubin in the circulation. This excessive unconjugated bilirubin in circulation will give rise to a yellowish discoloration of the skin and sclera. But because unconjugated bilirubin is not water soluble, it will not appear in urine. So the differential diagnosis of pure unconjugated hyperbilirubinemia and the other types, mixed or conjugated bilirubinemia, can be made with the visual examination of the urine, that if the urine color changes to brown, it means that there is conjugated bilirubinemia. But if the urine color is completely normal, on the face of skin color change, it means that the cause is unconjugated bilirubin. Another very common condition in general population, it is its prevalence is around 7%. There is a decreased activity of glucuronide transferase, and because of this decreased activity, unconjugated bilirubin cannot be completely converted to conjugated bilirubin, and in circulation there is an increased amount. This is called as Gilbert's syndrome. It is present in 7% of the population. And in these subjects, the health status is completely normal, and their survival is not affected. Even their survival may be better in comparison to general population, because unconjugated bilirubin in circulation is acting as an antioxidant, and it will prevent free radical damage. The differential diagnosis between unconjugated bilirubin elevation due to hemolysis and Gilbert syndrome can be made by the examination of the urine for urobilinogen. Because of the hypercirculation of unconjugated bilirubin, because the real amount is increased due to increased red cells destruction, urobilinogen in liver is found to be elevated. But in Gilbert syndrome, urine urobilinogen level is completely normal. So in this, with this examination, you can differentiate between unconjugated bilirubin due to hemolysis and unconjugated bilirubinemia, hyperbilirubinemia due to Gilbert's syndrome. We repeated unconjugated hemolysis, Gilbert syndrome, and another syndrome, which is complete absence of glucuronide transferase activity. This is called as Crigler-Najjar syndrome. And in this syndrome, there are two types. Type 1 is found in pediatric population, and it is not compatible with life as far as liver transplantation is not performed. Because of this, it is not found in adults, but this type is found in adults, and this is characterized by very, very high unconjugated bilirubin. The patients may suffer from disfigurement due to yellowish color, but otherwise it does not affect the general health of the person. There are two other genetic abnormalities, Dubbin-Johnson syndrome and Rotor syndrome. In these conditions, there is a mixed hyperbilirubinemia. These are also benign, and in the circulation, both unconjugated and conjugated bilirubin are elevated. The difference between them is that in Dubbin-Johnson syndrome, because there is a defect in the excretion of pigments from the liver is having a green-like color. The difference is that when we perform biopsy, the obtained liver tissue appears something like dark green to black. In Rotor syndrome, there is no color change in liver. We have already discussed that conjugated bilirubin can be excreted by urine because it is water soluble, but unconjugated bilirubin is not water soluble, it is lipid soluble, and it can only be excreted into bile ducts. It cannot be excreted in urine. And this is the urine with conjugated bilirubin, and this is normal urine. And the urine color in unconjugated bilirubin is like this as well, because unconjugated bilirubin is not excreted. But in this urine, there is conjugated bilirubin, but the same color may happen in hemoglobinuria or hematuria as well. In hematuria, there is red blood cells. In hemoglobinuria, there is hemoglobin. And hemoglobinuria may happen in hemolysis as well. So in hemolytic anemia, intravascular hemolysis, the urine color may be similar, but this is not due to bilirubin, but due to hemoglobin. What about mixed type bilirubinemia? So both unconjugated and conjugated bilirubin is elevated. This happens in injury of the liver. You remember we have covered too many conditions like hepatitis B, hepatitis C, fatty liver disease, and in all these diseases, both types of bilirubin are elevated in circulation, and there is bilirubinuria and the change in urine color. For example, acute hepatitis due to viruses, alcoholic damage, some drug toxicity. This is called as hepatotoxicity due to drugs. Some toxins, for example, amanitin from mushroom. And it would happen in canalicular cholestasis as well. Cholestasis means that there is an obstruction in bile ducts, and in this obstruction, the already converted conjugated bilirubin is refluxed into circulation. In a healthy subject, there is a very tiny amount or no conjugated bilirubin into circulation. But if there is liver damage, unconjugated bilirubin can be converted to conjugated bilirubin. This mechanism is not impaired in general, but the excretion into bile duct is impaired. So the conjugated bilirubin is refluxing into the circulation, and both unconjugated bilirubin and conjugated bilirubin are elevated. You see this cartoon is depicting the regurgitation process, uptake of unconjugated bilirubin, conversion to conjugated bilirubin, secretion into bile duct, but because of the obstruction, it is refluxing into circulation and causing bilirubinuria. In this type of disease, which affects bile ducts, bile ducts may be affected in several steps. For example, there may be a diffuse condition in liver, diffuse biliary diseases. In these diseases, there is mostly these diseases are either autoimmune or we do not know their etiology. All the bile duct epithelial cells are affected by this process, and there are obstructions. And due to this, there is an conjugated hyperbilirubinemia, and this type is called as intrahepatic cholestasis. On the other hand, if the disease affects left or right mean ducts, which are outside of the liver, common hepatic duct, or after cystic duct, common bile duct, if there is obstruction here, this is called as extrahepatic cholestasis. In extrahepatic cholestasis, the conjugated bilirubin level is elevated as well. This may be due to bile duct epithelial cell malignancy, cholangiocarcinoma, or pancreatic malignancy, because this area is covered the distal part of common bile duct is surrounded by pancreas, and pancreatic head tumors may result with cholestasis as well. So in general, cholestasis means that there is an obstruction in bile duct system. If it is diffuse and affecting all the intrahepatic bile ducts, it is called as intrahepatic cholestasis. If it is affecting the bile ducts outside of the liver, the large bile ducts, it is called as extrahepatic cholestasis. And common bile duct is opening into the second part of the duodenum in papilla vateri. We call this area is papilla vateri, and malignancies and fibrotic strictures of papilla vateri may result with cholestasis as well. And here you see again the extrahepatic biliary system, right, left hepatic ducts, common hepatic duct, cystic duct, and common bile duct. So any obstruction in these levels would result with cholestasis. For example, sclerosing cholangitis affecting bile duct, cholangiocarcinoma, pancreatic carcinoma, bile duct stones. Stone disease is very frequent. Actually, gallbladder stones are found in 20% of the population. So it will be diagnosed 1 in 5 in their lifetime. And 20% of these patients with gallbladder stone, there will be stone in common bile duct as well. Now we are switching to the case reviews, and you are going to diagnose the disease with me. 32 years old lady presented with abdominal swelling, increasing afternoon and evening for the last 5 years, and she told everyone asks if I am pregnant. She has constipation as well, on average 1 to 2 bowel movements per week. She also told she visited several doctors, many advices, many prescriptions without any avail. So you remember that this is a very classical history of a patient with irritable bowel syndrome. Irritable bowel syndrome is a symptom complex, mostly either constipation or diarrhea and bloating. We do not know the exact etiology. This is a diagnosis of exclusion. After excluding other type of bowel diseases like colonic carcinoma, inflammatory bowel disease, celiac disease, vascular diseases, and then we make the diagnosis of irritable bowel syndrome. So this is a syndrome rather than a disease because it's a symptom complex. Another patient, 55 years old male, presented with right hypochondrial fullness of 5 years of duration, say. The discomfort worsens in sitting position, especially while driving. His BMI is elevated. He is obese. Medical history is insignificant. He neither smokes nor consumes alcohol. His father is alive and also obese, and his mother has type 2 diabetes. This in physical examination of abdomen, the liver is palpable 3 centimeters below arcus costarum on midclavicular line in inspiration. The liver edge is relatively hard and tender that the patient stops respiration when the examiner hand touches the liver. So the liver is sensitive to palpation. This is a very classical history of a patient with fatty liver disease because the liver is enlarged. And you remember I told you that the liver is sensitive to enlargement. In this case, the Glisson capsule, which is covering the liver, is having pressure from liver, then it causes pain. And in these patients, generally there is obesity and a history of diabetes mellitus or insulin resistance in the family. Another patient, 27 years old woman, presents with pain in abdomen, which worsens with effort. She had a long-standing infection after delivery 2 years ago. Otherwise, her medical history is negative. Inspection of the abdomen reveals a slightly retracted abdomen with protuberance of left hypochondrial and colic regions. A close look reveals it's a solid and moves. It is a solid organ and moves with breathing. Of course, in the left hypochondrium, it is probably spleen. So the patient has splenomegaly. The palpation of the mass reveals that it's a moderately smooth mass which originates from left lower intrathoracic region. Its surface is smooth and it is not tender. The liver is not palpable and there is no ascites. In this patient, the final diagnosis is splenomegaly due to non-cirrhotic portal hypertension. Non-cirrhotic portal hypertension means that there is portal hypertension, varices, but no cirrhosis. In this patient, you remember in the history, there is an infection after delivery. So in this case, probably after delivery due to infection, thrombosis or portal vein developed, and it caused splenomegaly and esophageal varices. This is called as non-cirrhotic portal hypertension. Another patient, 55-year-old gentleman, presents with diarrheic episodes of 2 months of duration. Appetite is unimpaired and there is no weight loss. Abdominal palpation reveals an almost 7 centimeters measuring mass in the left iliac, left lower abdomen. It is hard and relatively fixated. And in this patient, the final diagnosis is advanced sigmoid carcinoma. In some patients with colonic carcinoma, the presentation will be with diarrhea rather than constipation. 29-year-old lady presents with progressive swelling of abdomen for a few months, loss of appetite and significant weight loss. Night sweating is reported as well. Abdominal inspection reveals a distended abdomen with effacement of umbilicus, so it is pointing towards ascites. Palpation reveals slight tenderness without rebound. Percussion reveals a dullness, which is also compatible with ascites in the lower part of the abdomen. However, dullness is homogeneous with intervening areas of tympanism. In this patient, the final diagnosis is peritonitis due to tuberculosis. Tuberculous peritonitis. So in a patient with ascites, if there are symptoms suggesting infection, tuberculous peritonitis should be considered. You are before a male, 49 years old, who came for a checkup, and his BMI is slightly increased, slightly overweight. His blood pressure is elevated, and he said his blood pressure is sometimes found high. In deep palpation of the abdomen, you feel the edge of something hard in the right colic region. It may be hepatomegaly, but in this patient, it is not, because this is an hydronephrosis of the right kidney. A right kidney may go into hydronephrosis due to infection, and it may be completely symptomless, and it may be discovered in a routine examinations. And you remember that while palpating the liver, you should take into account that in this region, kidney, adrenal gland problems and colonic problems may be confused with hepatomegaly. Another patient, 58-year-old man, was examined for the complaint of abdominal fullness and pain of nearly 1 year duration, no change in bowel habits, no weight loss. Abdominal examination revealed slight distension with sensitivity. Irritable bowel syndrome was considered and spasmolytics was prescribed. But the next day, patient's complaints increased and was admitted to the emergency unit with acute abdomen. And laparotomy was performed and revealed a distended and inflamed appendix and terminal ileum, and resection was performed and histology showed carcinoid tumor. So in the diagnosis of irritable bowel syndrome, you should try to discuss carcinoid tumors. Carcinoid tumors can be confused, may be confused with irritable bowel syndrome. Another patient, 31-year-old male, was admitted with upper GI bleeding. He did not require blood transfusion, and endoscopy revealed a probable resolving hemorrhagic gastritis. However, a later palpation of abdomen revealed a mass, which is not apparent in inspection, and the mass is filling all abdomen, except right inguinal region. And this mass was resected surgically. It was 25 centimeter, and that was schwannoma. You see that if an abdominal mass is increasing in size slowly, it may not cause any symptom. You see that there is a 25 centimeter mass, but the patient does not complain abdominal pain. Another case, 55 years old male is admitted with vague abdominal pain of 4 days of duration. The pain is diffuse and it is like a restlessness. The patient is obese. Inspection of abdomen did not reveal any abnormality. In palpation, there is diffuse slight guarding and rebound tenderness. In percussion, most of the abdomen is sounding tympanic, like an adynamic ileus. And bowel movements are infrequent. CRP is elevated. White blood cell count is also slightly elevated. And there is elevation in ALT. And in this patient, computed tomography reveals thrombosis of superior mesenteric and portal vein. Acute thrombosis of mesenteric veins would also result with abdominal pain and acute abdomen. High-dose unfractionated heparin is started. Another case, the patient is 38 years old male. He presented with diffuse abdominal pain of 6 months of duration, more prominent in the umbilical region. In the last months, loss of appetite, abdominal fullness, and malaise were added to the complaints. Physical examination did not reveal any abnormality, and there is slight iron deficiency anemia. Abdominal ultrasound did not reveal any abnormality, as well as upper and lower GI endoscopy. And 2 sequential diagnosis tests made the correct diagnosis. These sequential diagnostic tests first CT examination. It's suggested something wrong in small intestine, and small intestinal endoscopy revealed small intestine tumor. It is not usual in this age. Small intestinal tumors usually happens after the age of 60, but it may be. So this is something unusual in abdominal pain, but you should take into account small intestinal tumors in the differential diagnosis as well of abdominal pain. 48 years old woman presented with severe epigastric pain radiating to the back for 12 hours of duration. She vomited several times and she is unable to belch. Her past history is negative. The patient leans forward to relieve pain. This is very characteristic. This symptom is very characteristic of acute pancreatitis. Physical examination reveals slightly distended abdomen due to adynamic ileus, which also happens in acute pancreatitis. And in palpation, rebound tenderness is present, and in auscultation, bowel sounds are hypoactive. The final diagnosis is acute pancreatitis. 43 years old male admitted with severe epigastric pain of 1 hour duration. She is nauseated but did not vomit. And she also have hypoactivity of bowel as well. He admits a milder attack like this, but did not go to hospital, and pain relieved in an hour. This is very characteristic of acute cholecystitis. The acute cholecystitis or cholecystopathy presents with these symptoms. And the physician injects PPI with the diagnosis of gastritis, but in the next hour, the pain worsened and shaking chills happened, and the body temperature rise up to 39 degrees Celsius. And leukocytosis and CR, leukocytosis present, CRP is normal in the early stages. A diagnostic test is performed, that is ultrasonography. But in this patient, you expect that the Murphy area, you see the area under arcus costarum in mid-clavicular line. If you palpate here, there is pain in acute cholecystitis. So that will be all for this lecture. Thank you very much for listening. Nasıl hayatım? Nasıl hayatımı söyledim ya?